All right, should we call the meeting to order then with roll call?
This meeting is being recorded.
Can I ask who is taking the minutes for the meeting since Macaulay is on vacation?
We have board staff assigned to take the meeting minutes, as well as all of our meetings are now webcast and can be viewed on YouTube later on.
Okay.
So we will have ample abilities to recreate any of these meetings.
Okay. All right. Thanks, Loretta or Lori.
Either one is okay. No problem. Thank you.
All right.
And we're getting word that looks like Misa won't be able to log on, and I don't think we've actually made contact with the other two members. So perhaps we can just go ahead. And like I said, if we do lose a committee member at some point, looks like probably coming up pretty soon here, we would be best at that point to proceed with one of the agenda items that doesn't require any action from the committee. If necessary, you can certainly reorder the agenda to accommodate that and maybe do the presentation or something else that won't require committee action. But whoever it was that needed to drop off, if you would please just announce when you do that. We kind of need to keep track of when that happens. Thank you.
Possibly it'll fit during our presentation on newborn screening.
That's what I had in mind also.
Okay.
Yeah, I really apologize. It's just a time-sensitive lab draw that I could not get coverage for.
Okay, so moving forward with roll call. Do we have to actually physically call out people's names, or the fact that we can see you, is that good enough?
Just for the sake of the recording, just if you could just go through and
Okay.
either the committee chair can list off the names and people respond, or
Okay,
people can
that sounds fine.
chime in.
Mary Kay Phillips, that is me, and I am here. Jenna Shaw Batista.
Here.
Ruth Milkey. Not here. Hillary Reyes.
Here.
Misa Perron Burdick. Not here. James Byrne. Not here. And Rebecca DeSantis.
I'm here.
Okay, do we also need to call out Reza or the staff at BRN?
I'll just identify myself. This is Reza Pezhuhesh. I'm the BRN legal counsel.
And this is Loretta or Lori Melby, the board's executive officer.
Okay, so for the time being, we have a quorum. Do we want to proceed with the general instructions for the format of the meeting?
Good morning. This is the BRN moderator. I will be moderating the meeting. 1 second, please. Sorry. Sorry, let me try that again. Good morning. This is the BRN moderator. I will be moderating the meeting. To facilitate public comment, we will be utilizing the WebEx question and answer feature. When the committee reaches a point in the agenda at which public comment is appropriate, the question and answer feature will be turned on, and members of the public can indicate that they would like to make a comment by inserting the phrase "I would like to make a comment" in the question box, which is typically in the lower right of your screen. I will then call on the individual and unmute their microphone. The individual will have 2 minutes to make their comments. I will not give a warning as your time approaches. I will mute your microphone and will announce that your time has exceeded the time allotted. I will then move on to the next member of the public who has a comment. Please note that the question and answer feature is being used only as a means for members of the public to represent that they would like to make a verbal comment. This is not a means to ask questions of the moderator or members of the committee. Such inquiries submitted using this feature will not be answered. When asking a question, please make sure the question is directed at the host, me, in the dropdown. If any attendees utilize a profane name, they will not be called upon to prevent members of the public from being subject to profane language. While you are free to express criticism or negative views for the sake of the members of the public participating on the call, please do not use profane language when making public comments to the committee. I will provide a brief reminder of this approach at the start of each public comment item. Finally, when committee members or senior staff are not speaking, I would like to remind them to mute their microphone. If I detect background noise during the meeting as a result of unmuted microphones, I will interject with a brief friendly reminder.
Thank you. We are now going to move on to item 3, review and vote on whether to approve the previous meeting's minutes. Has everyone had a chance to review the previous meeting's minutes?
Yes.
Any questions or concerns?
This is Hillary. I'm just going to motion to approve the minutes.
Great. Do I have a second?
That's Jenna.
Jenna, do you second it?
Oh, yes.
Okay. So we have a motion to approve the previous meeting's minutes and a second. Should we vote?
Before going to the vote, just if we could open the line for any possible public comment, just in case. We
Okay.
can do that for each agenda item.
Thank you.
Moderator, would you please do that? Open it up for public comment.
We will be opening for public comment now. I will be activating the question and answer feature. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, I would like to make a comment. Please remember, you will have 2 minutes to make your comments. I will not give you reminders as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, I would like to make a comment. Committee Chair Phillips, there are no public requests for comment. Would you like me to close this window?
Yes, please. So now can we approve the minutes?
Yes, you can go ahead and take a roll call vote.
Yes. So Mary Kay Phillips, yes. And Jenna?
Yes, and I'll be ducking off shortly.
Okay. Ruth's not here. Hillary?
Yes.
Misa and James are still not on the call, I think. Rebecca?
Yes.
And that is 4. All approving the previous minutes. All right, let's move on to item number 4, public comments for items not on the agenda, items for future agendas.
We will be opening for public comment now. I will be activating the question and answer feature. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I will pause for a moment for members of the public to type in, "I would like to make a comment." Committee Chair Phillips, there are no public requests for comments. Would you like me to close this window?
Yes, please. Okay, moving on to agenda item 5, discussion and possible action regarding the current collection by the California Department of Public Health of data points identified in Senate Bill 1237 and possible recommendations from the committee with a presentation by Cdph on the newborn screening program. I'm going to recommend that we just move forward with the presentation because we won't have a quorum for probably the next 30 minutes. Is everyone in agreement with that?
Yes.
Okay. Is our presenter on the line?
Yes, I am.
Oh, great. I'm sorry, I'm not going to do a great job introducing you. Can you introduce yourself and tell us what you're going to present to us?
Yes.
Thank you.
Thank you, board members, and thank you to the Board of Registered Nursing for the opportunity to speak. My name is Joseph Domingo. I am with the California Department of Public Health newborn screening program, which is under the Center of Family Health genetic disease screening program. And if the board is okay with it, I could proceed with my presentation.
Please proceed.
Okay, thank you. And again, thank you again for the opportunity. This is, and thank you for your efforts to allow me to speak on behalf of the newborn screening program, talking about out-of-hospital newborn screenings for today's meeting. An expecting family's decision to deliver a child at home or at a birth center has and continues to be an increasingly popular choice. Nurse midwives in this capacity supporting and maintaining healthy pregnancies, attending deliveries, and providing the parent individualized care is an opportunity for newborn screenings to be performed. Next slide, please. Nurse midwives, nurse-wife practitioners at birth centers or within midwifery groups or as independent birth attendants are in a unique position to work with families to ensure this important testing is done and hence giving a child the best start in life. Next slide, please. What is screening? Screening, as defined by public health, is a measure designed to identify individuals in a population who may be at an increased risk of a certain disorder or disease. Next slide, please. Early identification, as far as the goals of newborn screening, of the newborn screening program, early identification of certain genetic disorders and diseases immediately after birth can prevent life-threatening illness, neurological or physical disabilities. When left untreated, can affect the child's quality of life. Timely detection through newborn screening can streamline treatment at the earliest opportunity. Next slide, please. A brief history of newborn screening. Dr. Guthrie, one of the pioneering physicians, created a simple inhibition assay was used to understand the high levels of PKU, which is phenylketonuria. This first blood test established the need for a simple system which could easily be transported and expand testing for treatable genetic disorders and to save lives. His legacy has continued to be a defining intervention in public health, credited with saving millions of children worldwide from severe developmental disabilities or early death. Next slide, please. California's newborn screening program came about 3 years later, in 1966, and also started the PKU test. As time has went on, we've evolved to over 80 disorders, and the newest addition is spinal muscular atrophy, which was added last year. Next slide, please. An integral part of the care of any newborn is the newborn screening test, and roughly 99% of babies born in the state are screened, and roughly 1 out of every 600 babies will have a rare but genetic and treatable genetic disorder. Next slide, please. As state law requires that all babies born in California have the newborn screening test, consistent with the preventative public health measures at the beginning of life, and this includes alternative birth centers at home or elsewhere. Because newborn screening is so successful, it is mandated by law under Title 17 of the California Code of Regulations, and states that all birth attendants are responsible for collecting specimens for NBS testing or documenting a parent's refusal for testing. Next slide, please. Newborn screening education materials are also essential for expecting parents and provides an understanding of the NBS test process, what is screened for, and to make informed decisions based on the outcome. Next slide, please. Important for all midwives to know is to fill out the appropriate paperwork and the specimens to ensure that they are sent within 1 day of collection. Most notably the test request form, which is formerly known as Cdph Form 4409. Next slide, please. So this is a visual of the TRF as well as the specimen collection card. And this is to your right is an actual visual of a child having their blood spot taken. Critical time to draw the NBS sample is 12 to 48 hours after birth. The responsibility of the nurse midwife, is informing the parents of the newborn screening test as early as in the prenatal stage or prior to the specimen's collection. The program emphasizes that the TRF be completed by all birth attendants in the most complete and thorough manner. Next slide, please. So this is a visual of the test request form, which comes with the specimen collection card. It's a carbon copy form, which has multiple layers. Those copies of the TRF, particularly the pink and blue copies, will be used for out-of-hospital birth registration within the respective counties, and if applicable, the newborn screening's regular provider. If you are the child's sole care provider at the time of birth, follow up with parents will be made right away, especially if a genetic disease is detected. Results are usually available within 2 weeks. NBS program staff will provide support and assistance with any required follow-up. Midwives should provide the pink and blue portions of the newborn screening test request form. Providing these colored copies of the forms will provide instruction on how to locate and what next steps are after the screen is done. Also, the pink and blue copy has information about privacy practices, specimen storage, and test refusal details. Next slide, please. The newborn screening mailer demonstrated here provides the most comprehensive information about a child's test. This is usually ordered by the child's pediatrician or immediate postpartum care provider listed on the form. This is crucial. Especially when a child has a detectable genetic disorder, but this is sent automatically by the program to the provider or the issuer of the TRF. Next slide, please. As the saying goes, with our program, it takes a village. Components consisting of the NBS process are far-reaching and multi-layered. All involved share a mission of giving all children the best start in life through this initial test, with a deeper commitment to making health and wellness possible for all children who are screened. It's a program and more than just a blood test. Next slide, please. Emphasized from the visual is the workflow. Was the workflow and the multi-componential parts that happen throughout this process. As different as it is within hospital, this requires additional steps both for the parent, the birth attendant, as well as the parent. So with out-of-hospital newborn screening tests, specimens are to be sent out in response are the responsibility of the nurse midwife, and relaying information about test results if a test is conducted. Next slide, please. And kind of to summarize most of what we've discussed in my slides, newborn screening is life-changing. It impacts the life quality of a child, not only in the near term, but over the life course. Newborn screening is mandatory. Nurse midwives are responsible for performing this essential test. Newborn screening is a multifaceted process with many stakeholders. It's of the interconnected nature, and to get all of our California newborn screens. And as said earlier, nurse midwives are in a unique position to work with families to ensure testing is done. And the emphasis is on saving lives through baby's first test. Next slide, please. Last but not least, I'm very informed by this work and inspired by one of my public health heroes, Sir Michael Marmot, and his tireless research and policy recommendations in social epidemiology. One of his guiding principles is the first out of the 6, which is give every child the best start in life. And baby's first test, newborn screening, exemplifies the need to conduct newborn screening so that every child has an opportunity to get that best start in life. I thank the board for the opportunity, and I yield back.
Thank you, Mr. Domingo. I appreciate the presentation. I'm not sure if there are any questions from the board regarding the presentation. Now would be the time to ask those questions. I have one, just as I mean, I'm just probably not knowledgeable, but for out of hospital births, when midwives are caring for patients in their home or in a birth center, I know this has a 40-hour window. So is the typical practice that the midwife follows through with the newborn screening, or is that then referred to like pediatric care or a lab, outpatient lab setting? What's the typical practice?
It's usually after the child is born, the midwife, the nurse midwife or the licensed midwife follows up 24 hours for the newborn screening test and collecting the samples. But I think key is that when parents be aware of the test and the process immediately after birth, or either that there's some sort of arrangement with a child's pediatrician within that time frame to get a newborn screening. But in this process, it's usually the nurse midwife or the birth attendant that performs a newborn screening test.
Is there any sort of check process like that, you know, based on like birth records or identification that, you know, a child was born, that the newborn screening was completed? So is there like a cross-reference to, you know, like birth certificate or other data collection?
You know, the test request form is, I guess, would be our notification, especially when it comes to submitting the form along with the specimens or with just the form if it is refused, so that we match our records. So the parent, so the parent would take the test request form to the out of hospital birth registration appointment with vital records, and they would enter that in tandem with registering the child and send that information to us so that we're able to locate the child's test request form or any newborn screening test information that they present at that point.
What can we do for you as the Nurse Midwife Advisory Committee with the BRN? Are you looking for any particular information on the website or links or follow-up action?
First, I just want to thank you all for the opportunity. I think that promoting and providing such outreach in this platform is a great opportunity to share with nurse midwives, not only in hospital, but out of hospital. I think a long-stemming partnership working with each other and promoting newborn screening, especially out of hospital newborn screening, is the way to go, as well as how shall I say, continuing the message of why it is so important for nurse midwives and all birth attendants to perform and get children, get all newborns born in the state to be tested.
Mr. Domingo, when you see refusals, was it in your slideshow or did I read elsewhere that can be based on religious objections? Is that primarily what's stated, or do parents have to state a reason for a refusal?
Parents, if they refuse, they could refuse on multiple, they could refuse for multiple reasons, but I don't think it's necessarily documented, but it could be for a variety of reasons. I don't think we necessarily ask for it, but what we do ask for is the parents to capture the parent's signature. And that's the responsibility of the nurse midwife who provides and offers the test. I think it is essential that if a parent refuses, that we have that documentation.
Any other questions from the committee? I don't think so. Moderator, is this something that we open up to the public for questions?
This is Reza. I think it would be good to open this up just in case there are any public comments.
Okay, thank you. So can we do that, please?
We will be opening for public comment now. I will be activating the question and answer feature. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Randy Shadle would like to make a comment. Go ahead, Randy.
Thank you very much. My name is Randy Shagel. I am a registered nurse, and I am the director for Area Service Center 96 for the California Newborn Screening Program. Thank you, Joseph, for presenting on our behalf this morning. I would like to clarify just briefly the refusal. According to Title 17, it does say religious beliefs. And we do ask, as Joseph mentioned, that whenever possible, we get the parents to sign off on that refusal. However, just to clarify, we do not check and we do not ask any questions or any follow-ups. Whenever we get a refusal, we accept it as is and move on from there. So I hope that clarifies that a little bit and provides a little bit more reassurance of the process. Thank you.
Thank you, Mr. Shadle. Tracy Bishop would like to make a comment. 1 second, please. Go ahead, Tracy.
All right. Thank you. Thank you, Joseph, for the presentation, and Randy for your clarification. I am Tracy Bishop. I'm the chief of the newborn screening section, and I just wanted to thank the committee again for this opportunity to present on our program, and we really look forward to the opportunity to work with you in terms of outreach of the importance of newborn screening and working with you to make sure that nurse midwives who do deliver at home understand their responsibilities. So thanks again.
Thank you, Tracy. Committee Chair Phillips, there are no other public requests for comments. Would you like me to close this window?
Yes, please. Okay, as a discussion, do the committee members believe that there's any sort of additional action or for like maybe future agenda item regarding the newborn screening that this committee should address? What are your comments?
Hi, this is Hillary. I'm having a memory of an issue where there wasn't so much an issue in obtaining the newborn screening, but that for some out-of-hospital practices, and perhaps this got resolved at another meeting, I can't remember, that there was some issue with reporting, getting the results. Maybe there can be comment on how the out-of-hospital practice midwife can easily obtain the results, unless that was, and anybody else can remember that issue.
Do the results typically go just to the parents, or do they come back to the provider who ordered the screen?
So this is Lori. I could chime in just a little bit to try to address this. There's a portal that Cdph utilizes, and if they're still on the call, they can talk about that, where the provider can log in and view results, and they can log in and order results. Currently, that is set up through Cdph, and it communicates for licensure verification through the med board, and now being added is the Board of Registered Nursing Licensees. We are in the process of updating that. The Board of Registered Nursing has signed the Memorandum of Understanding. The Board of Registered Nursing has given Cdph the accessibility to the three license types, I apologize, that would have access to this information. And the way that is set up is that our RN license can log in, establish an identity there and get verified, and they would have view-only rights The nurse practitioner and the nurse midwife could log in. They would have that higher license certificate, attached to the license validated. And that would then allow them to order. And so if the RN, because there are some facilities that use an RN in this role and not an NP or a midwife that has the ability to place the orders, that RN could be delegated authority from somebody else within that has a provider ID within that system. So it is branded as Ideal, which is the medical board branding. So they would still have to log in through that. The reason that has not been updated to date was this was expedited for us to accommodate accessibility to ordering and viewing the results. And so they gave us the minimum viable product, which did not change the med board signage and the med board's Ideal logo. So just to provide that clarification there, but it does allow for BRN licensees and certificate holders to view data and order data. And so that is in process. And if Cdph is on, they could speak more to that if they have that information.
Lori, do midwives or nurse practitioners have difficulty logging into the medical board? So is there like, I realize to get to the portal, like, are they looking for some kind of membership or license, medical license to even get into their website? Okay.
No, it is not required to have a medical license. It is required. That's why I was letting you guys know that we have the other license types that have been added to that. It is only required to have an RN to view and a nurse practitioner or a nurse midwife to order.
Okay, thank you.
Yeah.
Yep. I've been unmuted. This is Tracy Bishop. I really appreciate that, Loretta, but you're ahead of yourself. The prenatal screening program has access to a portal now. Newborn, we're behind. We don't quite have that yet. We're working on it.
Thank you.
Yeah, no, I just wanted to make sure everyone understood. And the way it works on our end is we send a copy of the results to the person who drew the test, whether it's the midwife or a hospital, and we send a second copy to the what we call the community clinician or the community PCP. So we do not send the newborn screening results directly to the family, but it goes to both the collector and the community provider that was listed on our test request form. Yeah.
But excuse me, Tracy, this is Mary Kay. Is the plan to make the site accessible so that there is a login and check result opportunity in the future?
It is, and I think for nurse midwives who draw it, it'll be relatively, because hopefully you'll have your yellow copy, and you'll be able to put in the test number and get a result directly. The big problem we have with newborn screening and results, as we're trying to conceptualize this portal, is common names and name changes, right? So, you know, the baby is born as, you know, baby boy Smith, but by the time they go for their first pediatrician visit, you know, they're Sam Jones, right? So the doctor's looking in the system for Sam Jones and can't find anything. So, you know, we're working on a way to give people access. But when we start, it's probably going to be people who drew the test because they'll have the test number from the form. I hope that helps a little. Yeah, it's a conundrum. We're working on how we might work it out better to make it, you know, more widely accessible.
Yes, thank you very much. Any other questions?
I was going to say if there is a provider, say for example, the parent doesn't have the pediatrician selected by the time the child's born, they can fill out a release of information, which is on our website. And all they would have to do is just fill in the requisite information along with the parent's consent signature and send that to us. They would get a similar result mailer that we would send to the person that's listed on the test request form.
And how quickly are these results resulted? So are parents told, you know, within 2 weeks, within a month, within 48, you know, what is the expectation?
I think you were spot on with the 2 weeks.
Okay.
Yes.
Okay. I don't think I have any more questions. Do any of the other committee members have questions? I think from our midwives in general, from the community, the big question is going to be accessing the results. So I'm glad we're working on that, or we at least have an answer.
Definitely. And nurse midwives, as well as providers, can access our website and go to the information for providers section of the newborn screening dedicated website.
Okay. Thank you, Mr. Domingo. Greatly appreciate the presentation. And we'll move on with a little bit more information from agenda item 5 regarding the current collection of data points. Did the committee members review any of the links associated with this agenda, the health and safety code sections? I think it was 102.415 and 102.426 and 102.430. Did you guys have a chance to look at those? So the question that I have regarding the collection of data points identified in Senate Bill 1237, and that is it section 8? Is that correct, Lori? I can't remember. Let's see.
I am sorry. Are you, is it the next agenda item? Which section?
Yeah, we're still on this agenda number 5,
Okay.
but part of agenda number 5 was kind of a review or question regarding the current collection of data points. And I guess the question that I had was on Health and Safety Code 102.415, it says that either so it says the physician or licensed midwife or certified midwife in attendance of the birth, or in the absence of either, the parents shall be responsible for entering the information on the certificate, securing the required signatures, and registering the certificate with the local registrar. For out-of-hospital births, does the BRN or what's the route, or what's the how do they have access to this certificate or the algorithm for registering the certificate with the local registrar? So if you're delivering out of hospital, how do you know that you've met these data points and you're submitting the right information?
One quick question of clarification. Is this continuing on the Cdph data collection, or are we talking about the data collection for the Department of Vital Statistics for like birth data?
Birth data.
It is not collected for the Board of Registered Nursing, but what we could do is we can reach out to the Department of Vital Statistics and have them do a presentation or get like an FAQ from them that I can share out.
Okay. I guess my my concern is I look through these items that they collect, the data. My personal concern is that midwifery data is collected appropriately and accurately throughout the state so that we have good numbers and good information regarding midwife deliveries. And so even in hospital births, sometimes I have concern that depending on the facility, that the information that is submitted is accurate. I know there have been cases, because midwives don't have admission privileges, that the birth record will include or have the backup physician or the supervising physician documented, and possibly not the midwife. So I'm just curious how we can like look at how this data is collected and make sure that we are being as accurate as possible with midwife numbers. Does that make sense?
Yes, it does. Is Cdph still on the call and able to be unmuted to speak on this? Because I believe even with the Department of Vital Statistics, that data comes either through or with Cdph. Again, it's outside of the jurisdiction of the Board of Registered Nursing, so I do not have that specific information.
You could visit the Vital Records website, our sister interdepartmental agency. I think they may have a database collecting this information, but this is also co-shared with the California Health and Human Services Agency. But there are more databases that I can't necessarily speak about, but if you look at their website, they do have an open data system that you could look at.
Okay, thank you. All right, I don't know of any other action that needs to take place with this agenda item 5. Committee, is there any other, can we move on, or is there any other questions for agenda item 5?
Hi, this is Hillary. I don't have any more questions, but I think you bring up a really good point about collecting these data points. And I apologize that I didn't open up these resources and look at it more closely. But I mean, I think the issue is how, as an advisory committee, how are we advising our constituents on meeting the requirements of the law, of the bill, right? To collect these data points. And if I'm, again, correct me if I'm wrong, that, right, we're waiting for future funds to be allocated towards this particular project? Or is this something separate?
That is with Cdph. That's not with BRN. So BRN would not be allocating funds to this future project. Again, they're separate jurisdictions. And right. The obtaining of the documentation, the information, the different data points is through Cdph. When the person was on, and if they're still on, they can open up and speak. They did talk about kind of working out some areas and then moving forward with that. So I'm not sure that funding is a limiting factor, but if they're on, they can speak.
So maybe this needs to be another future agenda item with a presentation from Cdph, I mean.
We can reach out, and it is, again, as the Joseph Domingo mentioned, that it is kind of a sister unit within Cdph, and within Cdph, they also partner with DHHS So we could get a presentation on it. I will defer to Reza legal counsel on that, just because we do try to keep items that are not under the BRN's jurisdiction separate from these meetings, but this may be something that we would include because it is in the bill and may require some clarification. But I will defer to Reza on that.
This is Reza. Can you just briefly restate what's the gist of the item? If it relates to
just how are we advising midwives on collecting data points? And it seems to be under the Cdph. So, and that I guess there was a provision in the bill. So maybe we're just required to have a frequently asked question about that. I mean, we've sort of been saying, okay, this is just shelved for the future.
Yeah, I think that's not out of the realm of what can be discussed by this committee. It could be potentially an FAQ. I think we even have on this agenda the discussion of various FAQs pertaining to the different sections of SB 1237.
Right.
And this may even fit there. I think bear with me.
Yeah, because I think that the whole part of the implementing the law about collecting data is something in the bill that we sort of do later when there's funds for it sometime in the future.
Yeah, so under SB 1237, if I'm on the same page as you, which I hope I am, the data collection by Cdph is discussed in section Business Professions Code, section 2746.55, which was under SB 1237, section 8, part of that bill, which on our agenda for today is agenda item 8. So if I'm on the same page and we're talking about the same thing, then
yes,
the FAQ about those data points could be brought up there. Does that help? Does that answer the question?
Yes, we'll move on with the agenda. And if when we get to agenda item 8, if we feel like we still have outstanding questions for maybe a future agenda item, we can propose that then. Does that sound good?
Yes.
Okay, great. All right, so let's move on to agenda item 6. Discussion and possible action, report from the subcommittee on the development of frequently asked questions, advisories, and regulatory revisions for section 4. This was the section that I worked on. Let me see if I can pull up what we, I'm sorry, give me 30 seconds here. So the FAQ that I submitted, if everyone has the detailed like supplementary items from the agenda, I think it is page 31, where for facts or FAQs and comments, I can read basically what I submitted. So what I believe, if we're going to list FAQs for the different sections of SB 1237, for section 4, to clarify, it authorizes CNMs to provide care for low-risk pregnancy and childbirth, and then we go on to explain what that is: prenatal, intrapartum, and postpartum care, interconception care, family planning care, and immediate care for the newborn, consistent with the core competencies of basic midwifery practice adopted by the ACNM as approved by the board. And then interconception and care for patients who fall outside of the independent scope of services, such as a patient with a previous cesarean section or surgery involving the myometrium, as long as the CNM has signed mutually agreed upon policies and procedures with a physician that delineate the parameters for consultation, collaboration, and transfer of care. I put an asterisk next to that section because I think we need to clarify that this does not mean supervision and is not a collaborative agreement. The language in a mutually agreed upon practice and procedure document should read a physician, not the physician. And the intent of the language is to ensure more access to midwives. It is not a new mechanism for requiring physician permission to practice via collaborative agreement, and this should be interpreted as liberally as possible. And that's all I suggested for section 4. Any comment from the committee?
I would certainly agree with your assessment on that, to make sure that we repeatedly and clearly state that the midwives do not need physician supervision, because it has been a barrier to care leading up to now, even after passing SB 1237.
Yes, I have received questions from midwives who practice out of hospital births and or do deliveries out of hospital, and the question was presented as like, when do I need a collaborative agreement? So I think there is some level of confusion on what we call this. We say it's not a collaborative agreement, but we call it a mutually agreed upon policies and procedures versus a collaborative agreement. So I think there's a lot of semantics going on there. But if we're creating FAQs for clarification, I'm hoping that clarifies it to some degree.
I feel like it does, but I am also not trying to implement as a certified nurse midwife at the moment.
Okay.
Any other comments?
This is Hillary.
Yes.
So I did I mean, it would be really helpful in all of this instance to have a link to some of the statements with some of the examples that have been given on the California Nurse Midwife Association website. And I think that they've made some documents that give examples of what it would look like, right?
Yes.
I mean, otherwise, I think in terms of a frequently asked question, it should be, let's clarify, like really use that verbiage, independent policies and procedure. I really like where you asterisked it. I think that's important. And here's a link to examples of how to word a specific policy and procedure.
So you're suggesting that when we post these FAQs, that we include like I envision like a link for the ACNM core competencies should be an automatic link, right?
Exactly. Yeah.
And then a link for a potential example of this mutually agreed upon policy and procedure.
Exactly.
And even if that link took them, if the CNMA already has these type of things, then the link could take them there.
Yeah.
Okay. That is also what I picture. We just don't know if a midwife is searching for answers that they're going to go to the BRN, you know, under what is available there first, or CNMA, you know, but I think we should be, we should have links that like they can find their information either for ACNM, CNMA, or SB 1237. Like,
Agreed. Agreed. I think it should be fluid through all those portals.
Okay. All right. Any other comment?
Just that I also concur. I like that.
I'm sorry, I didn't hear you.
Sorry, I'm very frightened. My voice does not always come through. Said I don't project as well. I also agree. I do like the links and the accessibility of examples as well.
Okay. I don't, we're doing this just for discussion. As far as possible action, do you guys feel like this is anything that we need to vote on, or is this just we're going over these FAQs and we're all saying yes, 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 or coming up with like maybe it should also say this, or this should be corrected, or I know that the FAQs will be reviewed by legal. I think that's correct, before anything is posted. Is that correct, Reza?
Yes, that's right.
Okay.
And so I
This is
don't.
Jen. Oh,
Go ahead.
Go ahead, Jenna.
hi, I was just going to say I agree with everything that's been stated about the links and guidance, posting the FAQs. I do think it's helpful for us to kind of talk through some of this. One small suggestion I have is potentially to remove the specific example of VBAC or uterine scarring. I do think it's really helpful to have examples to make things concrete. However, I hesitate to call any one thing out that then needs to be potentially updated in the future or become some sort of lightning rod. In particular, VBAC has been a very contentious political conversation. So that's just a comment for us to consider.
So your suggestion is to keep it more general and leave out like specific, like case example, to just maybe refer to like, I think in my statement I said previous cesarean section or surgery involving the myometrium.
Exactly.
Okay. I agree. We don't want to create situations where something's so specific that it becomes legal fodder, or I don't know. I don't have a good description, but I know what you're talking about. Okay, any other questions or concerns about what I submitted for section 4 of SB 1237? Should it be revised, or can you, anything I should add? Okay, now I have a question for Lori. Lori, when this agenda came out with, or the supplemental material, and we have all these links from sites on the BRN with all the dates next to them. As I went through that, I'm assuming these are all things that may be related to section 4 that we have to clean up. That currently the verbiage is not in compliance with SB 1237. Is that correct?
Not necessarily that you have to clean up, but to review for continued appropriateness and recency.
Okay. So there, under the future agenda items of the different sections, some of these are repeated. So I just want everyone to know that it's not like this gigantic list. Some of them are repeated, but I think we're going to have to plan for future agenda item that we look, or that we break these up, or we share them, or we need to, some organized fashion that we review these links on the BRN. Any comment?
This is Hillary. I mean, I would motion to equally divide up these advisories to as we're doing today, to then discuss them at the next meeting.
Okay. So what I could do, Hillary, is go through them and just make sure we're not like duplicating efforts, and then do a similar thing and just assign for review. And as I've looked through them, it's minimal language that needs to be corrected, but it does need to be corrected. So it's not like anyone's going to have to like rewrite, you know, in great detail, unless something's just completely out of date and doesn't have any relevance anymore. So if the committee is okay with that, we'll move on to agenda item 7.
I'm okay with that.
Okay.
Sounds great.
All right. And are we all 4 back on the call?
I believe so. I'm back. I've been back about a half hour now. This is Jenna.
Oh, okay. All right. Okay, great, Jenna. Thank you. All right, agenda item 7. Report from the subcommittee on the development of FAQs, advisories, or regulatory revisions for sections 5 through 7. Let's see. Jenna, this was this your area? Did you submit this information?
I did. I had somehow imagined it would be sort of morphed, or there'd be additional input from another committee member, but it looks like mine's the one that is in the packet. So I'd be happy to briefly talk you through it, but I just sort of approached it through the lens of some of the inquiries that I've been hearing from community and hospital administrators. And yeah, came up with some literal frequently asked questions in my attempt at a response.
I think that's totally reasonable. You know, we didn't have a set format or, you know, I guess format for how we were going to address these, but I agree with what you did there, because that's what an FAQ is all about, right? So if you want to review it for us.
Sure. I was just going to say it was a bit of an interesting challenge because I didn't, again, want to be too specific and write in more than is actually outlined in the regulatory language. So I referred back to sections of it a lot versus kind of restating it. And in the end, I'm not sure as a result how helpful it was, but I'll let you guys be the judge of that. So basically borrowed heavily from, I believe it was the CNMA examples, clarified, you know, in that first section of that physician supervision was removed, that we can directly procure supplies and devices, etc. And then also outlined how it is that we can furnish medications outside of scope with standardized procedures. And you'll see later on in this section, I tried to come up with an example of a standardized procedure, which was a request from folks in the community. very briefly answered exactly what medications may be furnished by CNM with and without a standardized procedure. Tried to define a standardized procedure, which is something that we had discussed in our last meeting as being potentially helpful, and attempted to address the question about what peer review would look like if it were meeting the requirements outlined in the regulatory language. So I can read some of it, or if you all don't have it pulled up in front of you.
I do, but I don't know if everyone does. Does anyone on the committee need Jenna to read for us, or is everyone looking at it?
It does look like I have it as well.
Okay.
I can.
I didn't quite catch that. Was the consensus that we're all reading it?
Yeah, Jenna,
Okay.
are you comfortable with submitting this as is for review, you know, by legal counsel with the BRN for?
I think so. You know,
Okay.
pending feedback from the committee, I did have a question about whether there was any, I guess maybe it is a question for legal review, you know, a definition of peer review that was implied that I wasn't aware of. I used sort of the standard peer review as I've seen defined in operation in healthcare, but I wasn't clear if there was a more specific definition that was intended. And I was curious about the group's thought about the standardized procedure example I pulled from a prior practice of mine, and again, didn't want to be prescriptive or too specific, but given that we did have a request, I sort of created a faux document with lots of potential topics, and then kind of expanded on one of the topics that could be contained in a standardized procedure document, which was therapeutic rest, which I felt was pretty benign if we were going to choose a specific example.
Right. And reading the example is perfect. It is probably how most midwives practice, but do we want to be so specific for this purposes, like even in the example, or you know, like I can envision it descriptive of just, you know, like saying medications, not specifically a particular order that's typically used, because I feel like over time that's going to change. Like there may be, or do we want to just leave it as a, oh, here's a typical example? I don't know.
I'm open to either one. Honestly, I also maybe did have a little bit of an ulterior motive, because I think sometimes folks outside of OB do not realize the dosing that is often used.
Oh yeah. Yeah, they get a little
And
excited.
yeah. And it's also a controlled substance, which is specifically named, but I could absolutely support, you know,
Right.
not specifying.
No, I agree. And, you know, I'm that provider that likes to do like 5 IM and 5 IV, and I always get a call back from pharmacy saying, you know, are you sure this is what you want to do? And yes, that's what I want to do. And no, I agree with you completely. Um, uh, Maybe we could word it where it just says, like, includes morphine, Vistaril, Phenergan, and maybe not. I don't know. I am being a devil's advocate here. It's actually fine with me, actually, as it's written. I'm not trying to create more work or something different. So everyone else agrees.
I do think that it just says it needs to include what drugs and devices and for what indications. I don't think it requires us to specify dosing, although that is typically included.
Mhm.
So I think it could be safely eliminated if people felt like it should be.
Sometimes I read these things, I try to look at them through a lens of, okay, like these other items that, you know, like 5 years from now, 10 years from now, we're looking at this FAQ and something might look, you know, something that's too specific might look grossly out of date, you know, but I don't, but um, we don't have to practice that way. Like we don't have to write things with the concern of how it's going to age. That doesn't have to happen.
I think this is really awesome, personally, as a Hillary. And I think it's really clear. And I think this is a standardized procedure example. It's not a recipe,
Okay.
right? So this is an example, a current example. I mean, I think we're talking about, you know, at some point setting up a schedule to review these advisories and freaking ask questions sort of on a, you know, every couple of year basis. So I think we can always re-update things if they become wholly out of date. But I mean, this has been a practice, I think, that I can remember for the last 30 years. It's pretty basic.
Okay. All right.
So I would say just not to belabor it and let's move on. And this is fantastic. Let's go.
Okay. So let's move on. Let's see, to 6. That's still you, Jenna. SB 1237, Section 6.
Yes. And I believe that Rebecca DeSantis weighed in too. Pretty straightforward, just clarifying that there are specific things, including episiotomy and laceration repair, which can be done without standardized procedures, and specifies, you know, the follow-up care needs to be arranged for. I struggled a little bit with this because I wanted to be very specific about how immediate care could occur without a physician on site. Keeping so that's why you'll see language like stabilization of parents while arranging for, or of patients while arranging for transfer of care. So I'm curious what you thought of how I kind of tried to wordsmith that.
Yeah, I like how you stated must ensure immediate care and stabilization of patients, because you don't want a midwife criticized for the care she provides, you know, in the interim. So by saying that she must ensure immediate care, her actions, I can only think of crazy examples, but you know, in order to stabilize or whatever, to decrease criticism of actions that she took for that purpose. Maybe there's a 3rd or 4th degree that's bleeding profusely, so she makes an effort to, you know, stabilize with some level of repair. you don't want her criticized for that, before transfer. Does that make sense?
Exactly. That's what I was trying to get at.
Mm-hmm. So,
I would agree with that as well. I mean, I don't want a midwife second guessing themselves on administering care when a patient is in need of it.
Right, exactly. So, I picture that like, hemorrhaging from a wound, albeit a 4th-degree laceration, she should do what she can and what she knows to repair that in order to stabilize the patient. So I like
I
how
think
it's worded.
this is a great example. I mean, obviously, another example could be, somebody shows up, crowning a breech birth or something crazy like that, right? You're not gonna just stop the process.
Right. Mm-hmm. That would be immediate care, like we've experienced. So I like the word must. I think that was a good choice of words. Must ensure immediate care and stabilization. So. Any other questions about section 6? We're all happy?
Yeah.
Okay. Let's see. Moving on to section 7. Regarding disclosures. Rebecca or Jenna, do you want to speak to that?
I think we both highlighted, the piece of disclosure that depending on the circumstances, the CNM is not supervised by a physician or surgeon. I wasn't sure if this felt like an exhaustive list or needed to be in terms of what disclosures would be included, but most of this was a CNMA suggestion and drew a little bit on, health literacy research on what needed to be included for understanding.
And just for clarification for me, so this disclosure, we are disclosing to the patient, is that correct? Who are we disclosing to?
Was my understanding.
Just the patient. There's not some public entity or
just the patient.
Okay. Or for hospital transfer or anything like that. We're not disclosing for anything else. Correct?
And in SB, and in the law, I didn't review this part, but is this disclosure verbal or does it have to be written?
My understanding is that it's written, but I don't know that I actually read that.
I think it's left ambiguously for emergency type situations, but ideally, yes, it would be written. But a verbal, I think, would be accepted in extenuating circumstances.
To go back, but my recollection was that it wasn't that specific and that I wrote written and verbal formats with translation in an attempt to ensure that client comprehension is achieved versus ticking the box that we handed them a piece of paper.
Okay. And then
I guess my idea would be that we're protecting the public as well as the practitioner so that there's not any future confusion, like let's say something untoward happened in an out-of-hospital setting and somebody wants to come back in a legal way and say, oh, nobody disclosed to me X, Y, Z.
this is Reza. If we're referring to the disclosure from Section 7 of SB 1237, which is Business Professions Code 2746.54, it talks about an oral and written disclosure. Does that answer?
It's under 10C. The Nurse Midwifery Advisory Committee, in consultation with the board, may recommend to the board the form for the written disclosure and informed consent statement required to be used by a certified nurse midwife under this section. So does the BRN have a location or like a form?
If you, so the statute lays out kind of the higher level requirements of the disclosure, as I said, oral and written form, and then subdivision A 1 through 10, identifies certain specific requirements. If this committee felt like it wanted to get more specific and maybe draw up a form or something like that, or just additional requirements relating to the form of the disclosure, you could do that by way of a recommendation to the board, and I think that would have to go through the regulatory process for the board to actually establish a regulation requiring additional requirements as to the form of that disclosure.
So the expectation is that prior to practice, or when a midwife takes on a client, that they create this disclosure. And according to this section 7 and then item 10, it says, in consultation with the board, may recommend to the board the form for the written disclosure and informed consent statement. So, Reza, you're suggesting that maybe we recommend that the board, like, there's a general form, or we create a general form, or we make a recommendation for a general form that the midwife could access. Is that correct?
Well, I think it's up to you. I'm not sure whether to recommend that, but you do have the discretion under the statute to do that. If you wanted to establish a specific, say, BRN standard form be drawn up and used, you could take that on, and one or a couple of you could prepare a form and bring it back and review it and recommend that the board establish that form as a required form for this informed consent. The board, if it liked the idea, would have to go through a regulatory process to establish a regulation saying that this is the mandatory form that has to be used. But if you wanted to establish a form, you could kind of get the ball rolling on that process by drawing it up and approving it within the committee and recommending that the board consider the form and go through the process to establish that.
Okay, thank you.
Mm-hmm.
Okay, committee, what do you think?
This is Jenna. I'm hesitant to endorse any specific required form because things will look different in different practices, but I do think that the community of midwives and potentially the public would also benefit from there being an example.
Mm-hmm. Okay. So do we want to make a future agenda item to discuss or create or submit or vote on or whatever a form or an example for section 7, item 10C?
I would say if we do make a recommendation, it just be like an example blank
Okay.
and not a hard and fast regulatory.
Okay. Okay. So I will make a note of that for a future agenda item. Okay.
Yeah, I don't know if there's any interest in a small subcommittee coming with some examples or an example, but I'd be willing to tackle that if that'd be helpful.
Yeah, that would be great, Jenna. If I could put your name behind it,
Sure.
that'd be great. Okay, thank you.
This
The
is
other-
Reza. Just real briefly on that, just to kind of play off what I said before and be more clear. If you are putting something out there as kind of an example, that's fine. If it does not go through the process of being established in regulation as a requirement, just keep in mind that you can't really go beyond requiring what's in the statute. So if you put out an example that says, here's how the form can look, just beware that it shouldn't really suggest that there are things required in the consent form besides what's in the statute, because it will only be an example, and we couldn't enforce anything that's not in the statute unless we go through the process of adopting that form as a required form through regulation. So perfectly fine what you're proposing to do, just keep that in mind to not kind of stray too far and throw in additional requirements that you think of, unless you're willing to take that to the board as a recommended requirement to be adopted through regulation.
So Reza, could an example be reviewed as, appropriate or by the committee, not a form that people have to use, but an example? Is it possible to still have that reviewed to see how appropriate it is?
Yeah, certainly. You could draw up the example and bring it back to the committee at a future meeting, and we can talk about it then. If there are concerns that, for example, if I spot things that imply requirements beyond what's in the statute, I'll make note of that. But otherwise, if the committee reviews the form that's put together and likes it, it can be put out there. It would just, we would try to make clear that it is as an example and not a required form.
Okay, great. Thank you. And Jenna and Rebecca, just another comment that I have about section 7, and I don't know if I'm off base here, but I never particularly like documentation that describes what is not. When I supervise residents and go over documenting, you can go down rabbit holes with what is not. Like, you are not. So I guess the way this is written, where the patient is retaining a certified nurse midwife, and the certified nurse midwife is not supervised by a physician and surgeon. I have a little bit of heartache with the way that's written, because is the assumption, so is the opposite assumed? I guess, is there an assumption that she should be, or that she would be, or he would be? Would it not be better to write further down where we say the certified nurse midwife is independently licensed and practicing midwifery, and in that regard is solely responsible for the services, without saying she's not supervised by a physician? In other words, just declaring independence. Am I making myself clear?
Definitely.
Okay.
I would agree too. The only problem that I worry about is the delay in care for some patients. So I can certainly understand the patient perspective on that end. Maybe something to the effect of this is appropriate and the standard of care throughout the US, or something to that effect.
Mm-hmm. Yeah, or maybe a reference to the independent practice of midwifery, you know, or something with the ACNM, or I don't know, but I just, we're also not supervised by, a particular, religious group or a particular whatever, we're not supervised. So just because we've recently gained this independence from supervision by physicians, I don't think we have to I think we should just declare ourselves as independent practitioners and not, oh, and by the way, we're not supervised by physicians. I don't know.
So this
Yeah.
is Lori. I'm going to interject really quick, and I like the conversation. I like how everything's going, and you guys are getting this information out. I want to remind that I know that you guys are looking at, as you just recently got this independent practice. That's wonderful. We're always looking at how the public can interpret and the lay person more specifically, so that we are very clear, so there's not any misunderstandings. And so previously there was within the public standpoint that that you guys were overseen by a physician. And so it may behoove us to continue, at least from the board's perspective, to put out the clarifying statements that means, no, they are no longer overseen by this. And so I want you guys, as you guys are going through these FAQs, to kind of remove yourself from the profession, remove yourself from kind of like these promotion of the profession kind of thought processes, and really go towards what is the public protection? What do we want our public to know so that they can make informed decisions? And so really explaining it down to a layperson level, and not look at, I really want to make sure that we're protecting our profession in the promotion of that. So, and then after saying that, I do want to do a time check. We have 33 minutes left of this committee, and we have not moved on to agenda item 8.0 or 9.0. And so we're looking at, once this goes to public comment, possibly if we were to end the discussion now, to possibly only have about 10-15 minutes for discussion of the remaining 2 agenda items. I don't want to rush you guys. So we may consider moving an agenda item to another meeting, or tabling this information, redoing this entire committee at another meeting as well, so we can have continued discussion on this, or we can help facilitate some work groups. And so I know that the chair had divided these up against 2 people work groups as to not violate Bagley-Keene. And maybe this greater discussion, more in depth, needs to occur with legal counsel, board staff, myself present, so we can have these in-depth discussions within those committees, and then bring that information back once these discussions have been completed. So I just want to throw that out to you guys to make a decision and allow the meeting to move forward.
Thank you. I was about to express similar sentiments about clarifying for the public. My suggestion is that if we are going to move these FAQs forward for section 7, that we insert a statement in the second one, what must be included in disclosures, that prior to the final statement, lack of supervision by a physician as applicable, that we insert the language, independent practice without supervision by a physician as applicable. Keep that short and sweet. And then in the example, elaborate much more on a midwife's appropriate independent practice. And leave it at that for now, so that we can move these FAQs forward while we're working on the example.
I agree with you, Jenna.
I agree as well.
So I think we can move on from 7. Let's see if we can get through, how quickly we can get through agenda item 8 and then make a decision if we need to push anything forward or meet at another time for continued discussion. But section 8.
Can I interrupt briefly?
Yes.
This is Reza. If we're moving on from agenda item 7, I think we should do a quick check to see if there's any public comment regarding any of the sections we just discussed, just real quickly. Also, I may have missed it. I don't know whether we took public comment regarding agenda item 6.
We did not.
If we did, great. Okay, if not, then perhaps we can just open it up now for comment on
6 and
anything
7.
that was discussed up until now.
Okay, thank you.
Thank you.
We will be opening for public comment now. I will be activating the question and answer feature. Please refer to the screen share for members of the public to see how they should type in the request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Committee Chair Phillips, there are no public requests for comment. Would you like me to close this window?
Yes, please. Okay, so moving on to agenda item 8. The FAQs or regulatory revisions for sections 8 through 10 of SB 1237. We do not have Dr. Byrne on the call. James is not here, correct? But all that's been submitted is that it appears consistent with MVC and L&M language and reasonable customary language. Does everyone agree with that? Are we okay with that? Not really submitting any particular FAQs?
I feel like the nice thing about FAQs is that we can revisit them later should we need to update. So I'm fine with moving forward.
Yeah, and section 8 is a lot of this data collection information. So if we have a future agenda item for an update from the Cdph on data collection, that may help us with any need for FAQs. Do you agree?
Like,
I'm sorry, who was
agree.
that? You agree? Okay.
Yeah, I agree.
All right. Should we go to public comment again for 8, or can we move on to
but I
agenda?
also agree.
Okay, great.
Just for clarification, Mary Kay, are you guys making a motion to not have any FAQs or regulatory revisions for the implementation of section 8.0 for SB 1237?
I think that's correct for at least the time being. Maybe
Okay.
we should say that we're going to revisit it after we follow
No
up.
need to say to revisit. That can be added as an agenda item at any time in the future in 2 months, 3 months, or even 6 years from now. So
Okay, so
there's
we'll say no FAQs at this time for section 8.
or regulatory proposed
Yes.
language.
Yes. Should we open that to public comment?
We will need a motion and a second, and then going out to public comment, and then a vote.
Okay.
I think there's no action being taken, right? Is that?
I think that's
am I
correct,
clear?
unless it's an action to not have FAQs for section 8.
Okay, I think we can get away with, not having to vote on a action of no action. So technically I think that's fine, and I think you could go ahead to public comment if you want to just tackle 9 and open it up to comment on 8 and 9 at the same time. That's probably fine. Normally we take comment on each agenda item, but
Right. Okay, so agenda item 9 is section 11. Hillary, can you comment?
Yeah, can you guys hear me?
Yes.
Okay, I just want to make sure I'm not on mute. It's the same thing. It's section 11 refers to this whole issue about collecting data for out-of-hospital births. So it has to do with the DHCS, or their right. So I think this falls under the same umbrella as this theme of how the bill wants us to collect data, and how, and we'll probably need to address this in the future, but we're not ready to address it yet.
Okay.
And I think at this particular section 11 is kind of self-explanatory, may not need a frequently asked question until we're ready.
Yes, I do.
Yes.
Okay. Then
And just also, since I would just want to add, since I was also assigned 12, 13, 14, and 12, 13, 14, we decided was just legal verbiage that related to, aligning our bill with the nurse practitioner bill, and doesn't at this point make sense to require, it's sort of more legalese. It isn't relevant. It doesn't require I don't think require frequently asked questions.
I agree. I've read through those as well, and I'm not sure what question's going to arise, but I don't think, other than the way it's written in the bill, I don't know that we need to write anymore at this point.
this is Reza. I think that's correct.
Okay. All right, so can we open for public comment for agenda items 8 and 9?
We will be opening for public comment now. I will be activating the question and answer feature. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Committee Chair Phillips, there are no public requests for comment. Would you like me to close this window?
Yes, please.
Mary Kay, this is Lori. I do have one clarifying question.
Sure.
So on agenda item 7.0 and 8.0, we currently have no FAQs coming from the committee, as well as no advisories or regulatory revisions. In agenda item 6.0, you do have some FAQs that will be coming to the board for our review and updating and posting to the webpage. Is that correct?
We have those for agenda item 6, but also agenda item 7, correct? We have FAQs from sections 5 through 7.
Okay, good. Thank you for that. So we will be expecting in board staff FAQs from 6.0, 7.0, no FAQs from 8.0, 9.0, no board advisories or regulatory revisions from any of the items for the implementation of SB 1237. Is that correct?
That's correct. Now, Lori,
Wonderful.
if it needs to be readdressed in the future, it's possible, correct?
Absolutely. At any point, we can always readdress.
Okay. Yes, that's correct.
Wonderful. Thank you so much.
So agenda item 10, discussion and possible action for the establishment of meeting dates for 2022. Does everybody have those potential dates? Let me pull them up. It looks like our first one would be February 8th. And then May 10th, August 9th, and November 8th. And as of right now, they're all projected to be teleconference. Is that correct, Lori?
We could only talk about through the end of January. That is when the newest provision that came out to allow us to be teleconference is in effect until. Following that, we cannot say whether or not it's going to be in person or teleconference, as we don't know if it'll be extended. However, with that, taking that into consideration, the Bagley-Keene does require to be in person. So if there are no further provisions granted after January 31st, then they will have to be in person. And Reza can explain much more of the details of what needs to occur for advisory committees and what the requirement for in-person is.
This is Reza. Can you hear me?
Yes.
Okay. So thanks for giving that caution, Lori. That's correct. We're currently operating under emergency authority that's been in place through the pandemic, allowing us to conduct these entirely remotely. If that authority is not extended and it concludes at the end of January 2022, then we would have to revert back to the ordinary way that we conducted our meetings before the pandemic under the Bagley-Keene Open Meeting Act. That would allow some remote participation, but we would have to hold have a physical meeting location with at least some members present there. So I think, I don't know that any of you would have taken part in meetings that were kind of under that prior framework. So you're probably used to this setup with everything being done by WebEx. But again, under that framework, there could be some remote participation by committee members, but we would need to offer a physical location and probably need to have some members there in person. So I can, I don't know if you want me to go into the real finer detail of it, but we'll have to also wait and see just what happens in the next month or two regarding whether the current revision is extended beyond January.
In the past, Reza, where was the meeting held when it was everyone had to be physically present?
It varied. We would hold them basically up and down the state. So usually Sacramento is one of the locations, but they also are held in various parts of the state. We were kind of required to spread the meetings around when we had physical meeting locations so that people in different parts of the state have an opportunity to attend. So it could be Northern California, Southern California, Bay Area, all over. It depends.
Okay. So can I suggest to the committee that when looking at these dates, before agreeing to the dates, that you're agreeing knowing that it could involve travel and, you know, physical presence for the meeting? Are there any, does anyone have any known conflict at this point with the projected dates?
This is Jenna. I don't think I have any conflicts. It does look, however, like the November date is election day. So if travel is required, that might make it challenging for anyone who isn't voting early by mail.
Yeah, that's a good point.
I am physically actually in the state of Georgia working on my PharmD. So if we can have a remote component for me, that would be extremely helpful.
Okay. Anyone else? And Reza, that's a possibility, correct? That some of the members meet in person, but possibly others are remote?
Yes, yeah, that is a possibility. We may have to kind of look at, there's two separate statutes under the Open Meeting Act that identify two different kind of sets of rules that these teleconference meetings could happen under, and depending on the circumstances, we might operate under one or the other. But either way, we could do a remote means of participation. We would just have to ensure that at least a minimal number of committee members are at the physical meeting location. Under one of the frameworks, it's a minimum of one member physically present. Under the other, it's a quorum, if I recall correctly, that have to be present. But that's something that we can kind of work out. Although there's a lot that goes into it. I don't want to go into the details too much because it's kind of uncertain at this point what we'll even be doing. But potentially, if you're participating remotely, you'd have to participate from a location where the public can also access it, and it has to meet certain requirements like ADA and a notice posted outside and all of that. So I would just, for right now, suggest, yeah, keep in mind the possibility of having to meet in person, at least with a certain number of the committee present in person. And as it gets closer, we'll evaluate which set of parameters will work the best and advise all of you more about, you know, the board making your travel arrangements and all of that, if that's what we're doing.
Okay, thank you, Reza.
I have one question. Are we going to be always meeting at 10 a.m. or possibly at, I mean, because sometimes we were meeting at noon? Or is that going to be?
I don't know how the time is determined. Maybe Lori can answer that question.
You
And then
guys
also
can
just
vote
to
on
say
that
that
here.
Ruth Milky texted me and she thought the meeting started at 12 today. And we also didn't get an email communication, usually like a few days before, about the time and how to access the meeting.
So you guys can vote today on the dates. You can even suggest a time and a length, and we can put that forward. And just for future knowledge, all of these meetings are posted 10 days in advance of the meeting date with an agenda. That agenda, when posted, is emailed out to our listserv If you're not a member of our listserv, which I recommend every RN in any capacity to be a member of our listserv, you can go onto our website under rn.ca.gov, and on the quick hits on the homepage, it says join our email list. And so anytime an agenda is posted, anytime materials are posted, anytime we send out an update, even an update from Cdph, it goes out to that listserv. So I do recommend that all of our committee members, including our advisory committees and our stakeholders and partners, join our email list so that they stay current on that. And then on our website, under the meetings, you will see that we have agenda and meeting materials posted. And within that agenda has the link for the WebEx, as well as a password in case it doesn't auto-populate for everybody to access. And so just as an expectation, we were doing some of the additional notifications out in email as you guys were a new committee. That is not typically our standard. We do rely on the agenda items being posted and those emails automatically going out. My board staff does work hard to get those additional emails out, but occasionally those would be missed if there's a sudden illness or a vacation or time off of some sort. And so I want to make sure that you guys have an ability to get those notifications, be aware that materials are posted, know where to look on our website, so that you guys can be proactive in that in case those don't come out. But as part of this vote, you can absolutely choose that you want to do a meeting on this date, that you would like all of your meetings to last 2.5 hours or 3 hours or whatever you guys want to do. And you guys can pick that you want to have your meetings begin at 10 a.m. and end at 12 p.m. or begin at 9 a.m. and end at 1 p.m. Whatever you guys want to choose, this is where you guys would make those recommendations, and we would take that into consideration when scheduling them out in the future.
Lori, what's our flexibility with the November 8th date? Since that is
You can move it to whatever date that you want to do. Taking into consideration, once you guys make those suggestions, I do need to make sure that it works with my board staff. It is really difficult. Like if someone were to pick like a January 4th meeting date, well, that's really difficult for us to do because we have to post 10 days in advance, which means it has to go through legal review, and that's right in the middle of the holidays. And so I would have this, limited staff available to do all of that. So when you put out a proposal, we'll look at the calendar and see that we can accommodate that.
Does it need to be on a Tuesday?
Tuesdays have been the established meeting dates for NPAC and NMAC, and we do try to schedule both of those committees on the same date. It seems to work best for my staff and everybody doing the prep work and getting this done, because it does take quite a lot of staff time to get these up and going. It also ends having like the same due date. So if I have a single liaison that's working for both the NMAC and NPAC, they're reminded that, okay, today I have to have all of the materials. Today I have to have all the materials to legal for review. Today I have to have all the materials posted or I need an agenda posted. If we start separating them out, it makes it very difficult for the staff to keep track of all of that. And with having upwards to 4 meetings a year for NPAC and 4 meetings a year for NMAC, including 4 meetings a year for our board and 4 meetings for our board committees, it becomes quite kind of a mess to manage. It's able to manage, but what you can do is if you want to move the November 8th meeting, you can give us a suggested date. I'll actually carry that suggested date over to the next meeting, which is our NPAC meeting that starts this afternoon, and see if I can get you guys to a lineup. I do understand that November 8th is a concern because it is, the election day, and I hear that. So that might be a same concern of the next committee. So you are able to give suggestions to whatever you guys want on this calendar. We will then, as board staff, finalize that and get it out to you guys and move forward going forward.
Okay, committee, how about I make the suggestion that we vote and accept these dates with the exception of November 8th and potentially move that to November 15th. Does anyone have a conflict or a disagreement with November 15th versus November 8th?
I do not. I think that's a good idea.
Okay,
I like that.
okay.
Agree. I
So
would like
let's,
to potentially talk about times though.
yes, so I am very flexible. Tell me what your concerns are and what your recommendation is.
My recommendation would be that as long as the meetings are virtual, that we do 3 hours at the beginning or the end of a day or over lunch to minimize the impact on work. And if we are meeting in person, then to plan the meeting in the middle of the day to potentially allow for travel before and after.
I think that's a great suggestion. And I think 3 hours is perfect. I think 2.5 is a little tight for some of our, agenda items, but or when we have presentations. So, and if we finish early, we finish early. That's wonderful. But I think to plan for 3 is probably a good idea. I am perfectly comfortable with over lunch meetings, even if we meet in person, that's how we plan it. So what are your thoughts?
This is Lori real quick. I do want to interject when you're talking about a 3-hour meeting. A lot of work was done this last year because of the implementation of SB 1237. That is not going to be the focus for the next year, as this should be implemented with the passing and review of these FAQs. And you guys did vote on the disciplinary guidelines and such. So I would like to actually recommend that we keep it at a 2-hour time mark with the flexibility to increase that if needed. If something were to arise, because you guys are having 4 meetings a year. In the past, the advisory committees only met 2 times per year. And so I would love just to kind of throw that out there, suggest that we keep it at around 2 hours. And if an agenda does call for a lengthier one, then we reach out to see if we can do it longer. But I was really kind of suggesting that a 2-hour mark would be good, as these will not be those types of lengthy discussions in the future, as SB 1237 after today's meeting has essentially been implemented.
Any
So if
thoughts?
we did that, would it be 11 to 1 or could it be, 9 to 11? It's just very challenging with 10 days notice to rearrange a clinical schedule.
I agree with that. What was suggested by another discussion here was for a morning or an afternoon start if it is remote, and middle of the day start if it is in person. My request is to be after 9 o'clock for remote, and ending around 4 or 4:30 for remote, so that my board staff has a chance to begin and end their day to get the committee up and running.
How does 2:30 to 4:30 p.m. sound for remote meetings to folks?
That is difficult for me at 4:30. I'm more likely to be interrupted anytime after 3, but I can work around it.
Okay, well, how about 9 to 11?
I think 9 to 11 or 10 to 12. For me, in the event that I'm working overnight the night before, sometimes that happens. To realistically be here and logged in or whatever the situation.
And
I
then
have
just
a
to point
letter
out to
from
you
the-
guys,
Because I'm
just to point out
it-
to you guys,
go ahead.
this is only for 4 days in an entire year.
Yes.
So
yes.
I'm hoping that we can come up with some sort of decision that we can relatively stick to,
Absolutely.
knowing that these meetings will now be scheduled out a year in advance. So hopefully you guys can adjust your clinical schedule to accommodate and not have a lot of interruptions or difficulties with quorums, as the intention is to set this calendar today for all of 2022.
Okay, would anyone like to propose a time that we can vote on?
I'd like to propose that we do remote meetings from 9 to 11.
A second.
All right. Let's take a vote. I will vote yes. And
This is
Jenna?
Hillary. I vote yes.
Okay.
Jenna, yes.
Rebecca, are you still on the call?
Rebecca, yes. Sorry.
Okay. So 9 to
Reza,
11.
do we need to go out to public comment? We did not go out to public comment
Oh,
before
I'm
the vote.
sorry.
Yeah, sorry. Thanks for catching that, Lori. Yeah, just in case there's anything
Sure.
they can bring up. Sure.
We will be opening for public comment now. I will be activating the question and answer feature. Please refer to the screen share for members of the public to see how they should type in the request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Committee Chair Phillips, there are no public requests for comment. Would you like me to close this window?
Yes, please. Okay, do we need to repeat that vote?
No, I think unless anyone's changed their mind on their vote, which there were no public comments to do that, I think it's fine.
Okay. Now, secondly, can we vote as a committee on the days? That's accepting the calendar as it's posted, except for the November 8th date and moving that to November 15th.
This is Hillary. I second the motion and vote yes.
Right. Mary Kay votes yes.
Rebecca votes yes.
Jenna, yes.
Okay, so that's everyone in favor of these dates. So we have February 8th, May 10th, August 9th, and November 15th. And currently they are scheduled as teleconference, and I guess we'll know after January whether that we proceed like that.
That is correct.
Okay, any other issue regarding the dates for future meetings or the time? Anything else? Nope.
No.
Okay.
You can go ahead and adjourn the meeting, Mary Kay.
Yes, so let's go ahead and adjourn I motion to adjourn the meeting.
A second.